invite our other members of the panel to the stage for the Ask the Experts session. I'll just remind you, thank you for highlighting the ATTEMPT trial that we have open at MCI. We also actually have the Destiny Breast 09 study open, so that first line study that's looking at TDXD and has the potential to maybe move that highly active ADC up to first line is also open at MCI. Okay, so now we have deliberately left the last half an hour for questions. We didn't take questions too much during the sessions. I'll open it to the floor if anyone has a specific question. If not, I'll ask a few to get the conversation going. And if we end up closing a little early, it's okay. We have the beautiful weather and the beach across the street to enjoy. Anyone with a question? Okay, so maybe I'll start with a few. So one of regarding the ADC talk, you brought up the issue of ILD pneumonitis. And I think a very practical point that a lot of us are struggling with in clinic is the monitoring strategy around that. CT scans every 6 weeks, every 9 weeks, 12 weeks. How are you approaching that?
Yeah, that's a great question and a very important one with ILD. You know, I think monitoring very closely for respiratory symptoms is key, and educating patients on when to reach out to their care team very promptly if they do develop is important. In terms of how we monitor for ILD, so many of the trials with TDXD did their scans every 6 weeks, checking for tumor response assessment, but also evaluation of pneumonitis. Practically, sometimes it's hard to get coverage for scans also every 6 weeks, and it is very prompt to scan patients, very frequent to scan patients every 6 weeks. So in practice with TDXD, you know, for other first-line approaches, one might scan every 3 months, but with TDXD, I do tend to do that at a shorter interval, and so I'm doing it every 9 weeks as kind of an intermediate, but being very cautious, and again with important emphasis on patient education on respiratory symptoms.
I'm following a similar approach. I think the thing that's very challenging with that drug is the issue that with many other agents with grade 2 toxicity, we don't have to discontinue. But here with grade 2, when someone is becoming symptomatic or has symptoms of any kind related to this issue, it's recommended to discontinue the drug. So that challenge of that right balance, I think, is something that we're all struggling with. Naomi, do you want to add anything? Are you doing anything different?
Not particularly anything different, but I do think it's just important to highlight that the median onset of ILD was something like 6 months. So, you know, I think people are talking about it a lot, and your nurses and your infusion nurses, everybody's talking about it a lot when we're first starting TDXD, but I think just remaining vigilant when you're a few months in and maybe it's not at the forefront of your mind anymore.
Right, right. Youssef, I want to get your input because I know at BOCA, at LCI, there's quite a bit of APBI going on there, and in terms of, you know, strategies that help tolerance for patients doing whole breast and having to come daily for a number of weeks. Can you talk to us about the patient that's appropriate for APBI and give us some education on that?
Sure, yeah. So with the advances in radiation therapy in the past 2 decades, particularly with the technological advances, also with studies maturing, we became more and more confident in reducing our targets. So in the old days, patients with early stage breast cancer, even small T1 tumors, even DCIS, the only option was to just irradiate the whole breast. Now with trials maturing and knowing more about the risk of recurrences, we became more and more confident in making our targets smaller. This has to be coupled also with advances in imaging. So whenever we have unifocal tumors, small tumors, T1, early T2s, certain age category, 50 years or older, and making sure that the margins are completely negative. We tend to like ER positive, no extensive LVSI, no extensive DCIS, so we work closely with the pathologists. So we cherry pick those patients, and lo and behold, we have about 50% of the cases that are early stage T1, T2, and 0 or DCIS that are eligible for partial breast irradiation. And this treatment has the advances of being shorter. So instead of going for the classical, 6 weeks or even the hypofractionated 4 weeks treatment, now these patients come in for only 5 sessions. And the territory of the irradiation, the extent of the radiation is much smaller. We're treating just the area of the lumpectomy with the margin, and the outcomes are excellent. The local controlled outcome are surpassing 90-95%. So we're very confident. Now, one challenging question we're facing in our region, and I practice at an area where we have, where 80 is the new 50, essentially. A lot of retirees and older generation, is endocrine therapy and partial breast irradiation. Many of our patients come to us, they say, can we use partial breast irradiation instead of taking endocrine therapy? We do not have the answer yet. There is a randomized trial happening in Europe about this question, the Europa trial. We're waiting for its results. They're randomizing these women to either endocrine therapy or partial breast irradiation. But basically for those patients who are candidates, it's really an excellent treatment options to be offered partial breast.
Thank you for that review. Just pausing, making sure we have any questions, feel free. Don't be shy, raise your hand, speak up, we're a small group.
Reshma, I want to revisit the point of pneumonitis
Sure.
with the TDXD, and because that does have some implications for radiation, especially these are patients who are metastatic. So I was wondering, I know it's, just looking at the table from the trial, it looked like maybe it was one patient, and the rate is really low, or maybe it was 1%. But I was wondering, maybe we'll know with time if that's more seen with patients that have extensive metastases, where there's like a florid kind of inflammatory reaction happening because of the drug effect, and that manifests as a grade 5 pneumonitis or excessive pneumonitis. So I was wondering if it's related at all to the extent of metastasis, or particularly lung involvement in those cases.
So those are great questions. There's been a lot of work that's been done to try to characterize what the risk factors have been for ILD pneumonitis, and a few things have kind of fallen out. One is in some of the earlier studies that included a higher dose. It seemed like there was a dose-dependent factor. Patients of Asian origin, Japanese descent seemed to be at higher risk. There was some link towards renal insufficiency and issues with maybe perhaps clearance of the drug that might be implicated. But I still think we have quite a bit of work to do. Now, recognize TDXD is being studied in patients with primary lung cancer. So the presence of lung metastases itself in my practice is not a deterrent to consider using the agent, although I will agree that a patient that has extensive lung mets and is symptomatic from that, sometimes it does make it a bit challenging when you're trying to discern if they're having symptoms from their tumor involvement versus from a drug effect. So it does become a bit challenging. Do you guys want to add anything?
That summarizes it perfectly. I think, as we also see some of the other ADCs being developed in this space, but particularly TDXD, again, in lung cancer, the rates of ILD, I do think have been notably higher with some of these agents in patients with lung cancer who were more likely to have had prior radiation as well. So I think it's a very important question that you raise, and that certainly requires some more study.
And it certainly, kind of goes back to the point of multidisciplinary care for these patients, because when these patients, come to us for palliative radiation therapy, or even in the definitive setting, and they've had these drug conjugates, we have to be more cognizant of the radiation dose to the lungs that they have received, and perhaps come up with more conformal techniques and more sophisticated techniques in order to avoid excessive lung dosing, knowing that they will be on the ADCs.
So Star, I have a question for you, recognizing you're not a plastic surgeon, but this has been something that's come about in the media. I've heard a bit, and I'm wondering if you have any comments on this code for the DEEP flap being taken away or something of that sort, and how that has maybe impacted care. Do you have any knowledge or comments on that?
At the moment, it hasn't impacted care in our practice at all, but I know that there is some sort of legislation in process that they're trying to make it more difficult to get reimbursed for a DIEP flap. A DIEP flap is an autologous tissue flap using your own abdominal tissue to create a new breast, and there's several ways to reconstruct a breast. At Miami Cancer Institute and a number of cancer institutes, the DIEP flap is not the most common way. We tend to use more implants, tissue expander, and implant-based reconstruction, but for some patients, either because they were previously radiated or their tissue expander or implant fails, or they just choose that they want to use their own tissue and they're good candidates for it, a DIEP flap is a very nice option. It's a much bigger operation, a more expensive operation, I'm sure, and it has some additional complications that are associated with it and sometimes a little bit more of a lengthy hospital stay. So I'm sure there's pros and cons to doing the DIEP flap, and that's part of the reason why it's being legislated. But historically in the United States, breast reconstruction has been extremely well protected, meaning that if an insurance company covers a mastectomy in the United States, they have to cover reconstruction. So it's not surprising that this is now being like hotly contested, that they're trying to block DIEP flap reimbursement. And I think, I'm not sure what the status of it is at this moment, but I know that the plastic surgery societies are being very vocal about it, and I have a feeling that the DIEP flap and autologous tissue reconstruction is going to be here to stay.
Yeah, it's been interesting to follow that story in the news, and I think some patients have started to ask about it as well, so thanks for giving us that background. And you brought up the issue of implants, and this kind of ties together with something that Maria, I'm going to ask you to comment on, with the link towards these issues with implants and lymphomas related to implants and all of the kind of news that is out there that patients get very anxious about. I'm wondering, first of all, if you can just give us some background on, how common that is. And from Maria, from your perspective, I see a lot of patients who are dealing with the anxiety of a lot of these issues and end up coming to you for some counseling. So I'd like you both to kind of weigh in on that.
So implant-associated lymphoma is extremely uncommon. We've seen one case at MCI in my practice, and the plastic surgeons as a whole in our practice have seen single digits of cases. Very, very, very rare. But it's gotten a lot of media attention, as does any complication with prosthetic biologic aging usually does. But it's a rare type of lymphoma that's associated mostly with a breast implant that has a rough textured capsule. And since this was associated to be some sort of risk factor for a breast lymphoma, those implants have been taken off the market and recalled. And so most breast implants that are being placed today in the United States are not going to have risk factors for this implant-associated lymphoma. The signs that you should be concerned about if you were to develop a sudden onset of swelling around the implant, or like a pericapsular fluid collection around the implant, and the implant's at least 2 years old, especially if it's an old implant that has a rough or textured capsule, the first step in diagnosing this would be to probably either be an ultrasound or breast MRI, but ultrasound can actually identify that fluid collection, and then we do an aspiration or take some of that fluid out from around the implant and send it to pathology for them to test the cytology. And if there is a suspicion that this is an implant-associated lymphoma, then the treatment is to remove the entire capsule and block with the implant. And usually this is curative. So these have excellent prognosis, an excellent prognosis when they are diagnosed, and they're usually caught early enough. And I can't stress enough that they're extremely rare. It is not a reason to not undergo implant reconstruction. We rarely see these.
Uncertainty causes anxiety, and unfortunately patients go to the internet and they find information where they should not be finding information. So I think talking to patients and explaining the probability of this is like a rare condition and explaining the data in a way that they understand, that decreases anxiety. And ask them then the opportunity during the appointment, do you have any fears, any concerns, and asking uncomfortable questions, meaning like, how are you emotionally handling this? What are your fears? So in providing data helps with uncertainty.
Yeah, I think that's really valuable feedback, because I think as physicians who are counseling them on their treatment decisions, the emotional aspects of things are things that sometimes we don't get a chance to dive into too deeply, and having the support of the other members of the healthcare team is really helpful in that regard. I think there was a question. Sorry, the light's shining in my face, so.
No problem, thank you. This is going back to the prior conversation about pneumonitis and lung cancer. The panel spoke very robustly about metastatic disease in the axillary area, and I'm just wondering for some questions, just confirmation for me, is when you leave the lymphatic tissue there and the patients have metastasis, is there a pathway consideration in saying why the patients would have this increased pneumonitis if they have lung cancer, or how does that relate to radiation as well? So it's a two-point question.
I could take the question. So great question. So essentially, when patients come to us and we assess the case and there is a need for radiation therapy, we assess how much of radiation therapy we need to give. As we discussed earlier, there are patients that just giving partial breast irradiation is enough, and there are patients like the case that we presented today that require treatment to the chest wall, but also regional lymphatics. That means the axilla, the supraclav. Now, it's true that our radiation techniques have improved with time, but there will always be a collateral dose of radiation that goes to the lungs. So with time, we've learned how much of a radiation dose the lung can take, and we have very hard stops beyond which we cannot exceed. So this involves people who work with us beyond the scenes, physicists, dosimetrists, before we put the patient under the radiation treatment. So there's a lot of quality assurance goes on before that's the case. Having said that, there is a risk of pneumonitis happening. So that's why we see patients in follow-up. Typically, the pneumonitis that happens related to radiation therapy, if we are compliant with the radiation tolerance of the lungs, typically happens 6 to 12 weeks after the treatment is over. And that's why patients come in for follow-up around that time to see if any of those signs are showing up. If it is showing up and we catch it early, most of the cases, I would say 95% of the cases, are treated effectively with a short course of corticosteroids. And then it resolves. So it's all weighing risks and benefits. I don't know if I answered your question.
Other questions?
Hi, Jose Ortega from Hematology Oncology Associates of the Palm Beaches. Could you please describe your adjuvant endocrine therapy approach for a triple positive premenopausal patient?
So I would generally use the same principles in HER2 positive as I use in the HER2 negative hormone receptor positive space. Being premenopausal, given these kind of updates from soft and text, I think if there is that, tumor being 2 centimeters or greater, a grade 3 tumor, or a patient who's under 35 years of age, there's good data for doing the ovarian function suppression plus AI. I thought it was really interesting in this update that they gave a lot of subgroup analyses regarding the HER2 positive subgroup versus the HER2 negative subgroup. I had kind of always had this kind of paradigm that patients with HER2 positive breast cancer didn't respond as well to tamoxifen. That's something that we've discussed. And again, it was a small subgroup in soft and text that were HER2 positive, but it actually seemed that the majority of the benefit from AI and OFS was in the HER2 negative subgroup, and there was a suggestion of benefit from tamoxifen in HER2 positive. So that's certainly something that I'm going to be thinking about going forward, although it was a small subgroup, so I don't know that I would really change practice based on that, but it is food for thought. So, in general, that's when I would be applying the ovarian function suppression and AI with those kind of higher risk subgroups. And then, again, for 5 years versus 10 years, would be thinking about, again, kind of higher risk situations such as lymph node positive or larger tumors, to consider that extended adjuvant therapy, but I do like getting a breast cancer index just because I think patients really like to have that information, particularly if we're telling them you don't need 10 years and they're like, I don't want to come off. I feel, more comfortable being on it when they see a test that shows them there's no benefit from 10 years. I think that can help them to feel comfortable coming off, and the BCI has been validated in HER2 positive cohorts as well. So I think we can still use BCI for these triple positive patients.
Anything to add, Anna?
No, I agree with what Naomi said. I think, use the same characteristics, the same clinical and pathologic features in HER2 positive, hormone receptor positive, or hormone receptor negative patients to define in which patients I consider adding ovarian suppression. So for those patients with hormone receptor positive, HER2 positive, hormone receptor positive, HER2 negative breast cancer, it's tumor size, it's nodal status, it's grade 3 tumors, that young age. So using ovarian function suppression, an attempt in combination with AI, particularly for those higher risk patients where we know that OFS plus AI may add a little bit more than OFS plus TAM. Than tamoxifen. That said, it is a challenge sometimes from a tolerance perspective, the OFS plus AI approach. And so particularly for those HER2 positive patients, given the subgroup analyses that Naomi was just referring to, I do feel comfortable switching to OFS plus tamoxifen particularly. But again, it's the higher risk clinical and pathologic features that drive that addition of ovarian suppression, regardless of HER2 status.
When you've determined that a patient will benefit from extended adjuvant endocrine therapy, how do you decide between 7 to 10 years of therapy? And tied to that, how long do you continue the ovarian function suppression in those who are receiving it?
So I'm doing the ovarian function suppression for 5 years, although I do think there was recent data that was looking at, was it 2 years? For ovarian function suppression, I still kind of use 5 as my standard, but again, if they were tolerating horribly and it was really making them miserable, I wouldn't necessarily, push them to the full 5 years. And I think kind of similarly in terms of the adjuvant endocrine therapy, the AI, I tend to use 10 years as my extended adjuvant. However, if they really are having, usually at that point, if they've made it past 5 years, they're not having too tough of a time with it, but that might be more of when you're running into bone density issues. So given some of the data that we have for, more of like a 7.5-year kind of situation, if we were running into issues with bone density, I wouldn't be, hesitating to stop at the 7.5.
So the only data that I would add to that is if you look at the IDEAL trial, where the breast cancer index was actually validated, that was one of the data sets. The events that happened after, so it was 5 years of upfront adjuvant, and it was either 2.5 or 5 years of an AI. The events that happened in the first 2.5 years were not counted on either arm because both groups were on the AI. So the BCI was able to actually discriminate who needed longer 10 years of endocrine therapy. So that's been informative for me that if I am going to order a breast cancer index, I am trying to extend that patient to 10 years based on that data, but certainly toxicity and how the patient's tolerating it, bone density issues factor in. I think the OFS question is a little challenging in patients that are perimenopausal, right? So when you're looking at adding ovarian suppression to a patient who your menopausal status is not clear, you're erring on the side of caution and adding the OFS, but now 5 years in, she's 53, she's 54, and she's coming every month for the shots, and maybe she's gone into natural menopause. The only way to really know is to take her off of it, but then you're worried that she's off and she's on an AI and she's going to call you and say, I've had a menstrual period. So it's done with a lot of caution that if they're of the age group that you think they may have gone into natural menopause, to take them off and carefully monitor estradiol levels, knowing that if the patient's on tamoxifen, FSH and LH is not going to be reliable. So I think it becomes a bit challenging.
You know, I agree. I would add, though, particularly for those patients who are closer to perimenopausal age, and you know that you want to plan for an extended duration of endocrine therapy, though, for example, you know, someone with, again, a larger tumor, multiple positive nodes, and in whom you're planning for that extended period of endocrine therapy, that also you could make an argument, and particularly in that patient population, for oophorectomy towards the end of their 40s, once they're done with childbearing, particularly also, you know, so when that patient comes out at that 5-year period and you're struggling with what to do with the ovarian suppression, you can avoid those issues. And I think many patients end up electing to go down that route and pursue oophorectomy. It also gives them more peace of mind that they're adequately suppressed. You're not checking FSH, estradiol routinely, or worried about breakthrough bleeding. So that's also something I think to consider, particularly when, you know, after 45.
So in the last few minutes, I'm just going to take the opportunity to do a rapid fire question to all of you. Very quickly, just give us a soundbite about what you're most excited about in your area, anything new and upcoming, a trial that you're very anxiously awaiting the results of, or anything for a forward-looking statement.
In ADCs?
And anything breast cancer.
So specifically related to ADCs, I think there are many exciting trials that we're going to hear about soon. You know, a few that I would highlight probably are DB06. So looking at trastuzumab deruxtecan potentially in an earlier line setting as the first chemo-like approach for hormone receptor positive, HER2 negative breast cancer. And particularly interested in looking at some of the data in those higher risk patients in the adjuvant setting. So data from the COMPASS HER2 studies and DB04 as well. So I think that those are potentially practice-changing clinical trials if they do meet their primary endpoints, and hopefully we'll see results soon.
That's a reminder, that's the other study I forgot to tell you all. COMPASS RD is open at Boca Hospital. Lynn?
As our systemic therapies continue to improve and targeted therapies improve, we're seeing more and more pathologic complete response rates, specifically in the HER2 positive and triple negative breast cancers. And I think it's going to be very exciting to see in these patients that have complete pathologic responses, their very long-term outcomes, and who eventually may be able to avoid surgery altogether. And so there's a trial out of MD Anderson looking specifically at this question. I think it will be a while before patients are deemed like not needing surgery at all. But there is, I think, in the future going to be a subset of patients that are going to be treated medically alone and won't require surgery, and that's very, very exciting. Even though I'm a surgeon and I love to operate, if that puts me out of business, I'll be very happy.
Lots of exciting things to look forward to, but just a couple in the short term would be seeing the actual data from the NATALY trial for adjuvant ribociclib that we got the press release about a clinically meaningful benefit. And then in the longer term, the NRG09 trial that I had mentioned that's going to really answer this question of whether the premenopausal lymph node positive women truly need chemotherapy or whether ovarian function suppression will achieve the same result.
From a radiation perspective, there's really a lot to look forward to in the next few years. The one particular area I'm looking forward to is de-escalation of treatment for specific patients based on biological subtype and the response to neoadjuvant therapies. I mentioned the NSABP B51 study. We'll be hearing about it shortly, hopefully in the next couple of months, maybe this ASTRO, who knows. Along these lines, also tailoring radiation therapy to biological subtypes. So as radiation oncologists, our trials are a little bit lagging behind. Our colleagues in medical oncology are moving way ahead of us, much faster than us. And we need to catch up in terms of kind of personalizing radiation therapy to biological subtype of each patient. So a lot to look forward to.
And for me, I'm glad you guys are doing a lot of research. There are going to be more survivors. And I'm interested in cognition and memory, chemo brain. So hopefully we'll continue studying that and support patients during their survivorship.
So in the next 2 hours, just kidding, April Fool's Day. Enjoy the rest of your day. Thank you all for coming. You forgot, it's April Fool's Day.
Is there any, thank you for a great conference. I appreciate that. I guess everybody else here does too. But I wanted to ask you, is there any comment on the use of artificial intelligence for the diagnosis of breast cancer?
Yeah, there is, and it's very exciting, specifically in reading of mammograms. So there's going to be a lot coming out, I think, in the near future about using AI to help predict who's going to develop breast cancer. I think this is going to be the future of screening, that they're going to be using more and more AI, because AI can see these patterns. When you feed in 10 years of mammograms on someone who eventually develops breast cancer, it's starting to be able to pick up patterns and being able to predict who actually develops breast cancer.
And not just screening and diagnosis, but also for treatment as well. So for example, improving methods of quantification of targets such as HER2 based on AI methods. I think there's a lot of interest in that space, just given some of the data that we've seen of benefits regardless of target expression. For example, can we better quantify and identify biomarkers for specific therapies using AI methods?
Great, so thank you all for your attendance. Please check out on the Total Health website. We have future programs coming up. Some are evening programs, some are half-day programs. Raquel, I think you had a...
Thank you everyone for coming. If you could just fill out your CME evaluations on the website and the survey, and if you could return your lanyards and badges to the registration stand so that we can recycle them. Thank you.
Thanks again. Have a great rest of your weekend.